So without further ado, I want to welcome our first speaker, Patrick Bossuyt from University of Amsterdam. His talk is From Biomarkers to Medical Tests about Pitfalls and Peaks. Patrick is Professor of Clinical Epidemiology and acts as the Chair of Division of Public Health and Clinical Methods in the Academic Medical Centre. His work spans a broad range of clinical research with an emphasis on studies to consider the effectiveness of clinical interventions to guide recommendations and coverage decisions. He leads the Biomarker and Test Evaluation Research Programme in Amsterdam, which aims to appraise and develop methods for evaluating medical tests and biomarkers to apply to these relevant clinical studies. He also serves on the editorial board of a number of peer-reviewed publications, including radiology and clinical chemistry, chairs the Scientific Advisory Committee of the Dutch Health Insurance Board, and is a member of the Scientific Advisory Board here at Alstom. So thank you, Patrick, and we look forward to hearing from you.
I'd like to thank the organizers for the privilege and the honor of presenting here today about biomarkers and medical tests. I'd like to offer my disclosures. I'm a member of the Alstom Medical Scientific Advisory Board, but in this presentation, I will not discuss Alstom. I don't think I have an actual or potential conflict of interest in relation to this presentation or any of the products mentioned in it. I should also disclose that I have helped to develop the START reporting guidelines, which I will mention, and that I participate in the Reward Alliance to reduce avoidable waste in research. Allow me to say a few more things about myself, where I come from. In a literal sense, I come from Belgium, Flanders. Bossuyt or Bossuyt is a very small village, very close to the French border in Belgium. But I moved to the Netherlands and I'm now working in Amsterdam at the Amsterdam University Medical Centers. And these medical centers are two hospitals in Amsterdam, one to the west, one to the southeast. And each one of them houses a school of public health and a medical school. And I arrived there around 30 years ago as a clinical epidemiologist. And in the Amsterdam University Medical Centers, clinical epidemiologists like myself sit down with clinicians from all specialty areas to design, run, analyze, and report studies. Most of these studies are clinical studies in patients to evaluate the effectiveness of interventions, new drugs, new surgical interventions, all medical specialties. But over the years, I've tried to specialize more or less in the evaluation of medical tests. It's relatively straightforward to find out whether a new treatment is beneficial for patients, but it's much more difficult to develop recommendations about medical testing in imaging, in laboratory medicine, in genetics, in breath testing. How do you find out whether tests are worth recommending? And how do you find out whether patients are better off from being tested on average? Or there may be benefits elsewhere in the healthcare system, for example, a more efficient process. And based on that 30 years of knowledge of evaluating medical tests, I've prepared this presentation. I will discuss the biomarker pipeline and then present a systematic review, first focused on the methods of the studies in biomarker evaluations, and then I will spend some time discussing spin in biomarker evaluations. Thereafter, I will offer a few reflections on the biomarker pipeline and end with a short coda. And the takeaway messages are maybe not surprising for methodologists. We need stronger studies in biomarker evaluation. But we also need better reporting and less spin in these study reports. My final argument will be that the biomarker pipeline is broken, and then we need to change from a discovery phase in extreme phenotypes to a focus on unmet clinical needs in target populations. First, a few thoughts about biomarkers and medical tests. Over the years, I've witnessed the gradual increase of biomarker evaluations in the medical literature. This slide shows the number of records indexed in PubMed that have biomarker in the abstract or the title. There were a handful in 1990-91 when I arrived at Amsterdam University Medical Center. But last year, for example, we observed more than 30,000 articles indexed in PubMed that had biomarker in the abstract or a title. And in a cumulative way, that represents thousands and thousands of articles on biomarkers. Now, these articles are referring to specific elements in what is considered the biomarker pipeline. And there have been a number of alternative presentations of the biomarker pipeline, but what I'm presenting here is, you could say, a summary of these analyses of the biomarker pipeline. And they start with a discovery phase, where researchers try to discover biomarkers for a specific area. And after discovery, there's a phase of validation. So once discovered, a biomarker has to be validated as such. And once it has been validated, it has to be translated into clinical practice. And in these phases, there's usually the development of an assay, a validated assay, to measure the biomarker. And with that translation, it can be evaluated in clinical practice in terms of the questions that I expressed earlier. What's the clinical performance and the clinical benefit and utility of that biomarker? And if the evaluation is successful, the marker can be implemented in clinical practice. So we have seen these massive research efforts, but have they produced biomarkers that can be implemented in clinical practice? Well, to answer that question, whether they can be implemented, we have to evaluate their performance. And we can do so by answering three questions. The first question is, can I trust the result from the tests? So once a biomarker is available in an assay, and the assay is a medical test, can I trust the results of that test? And these are questions about the technical or analytical performance of the test of which we speak. Thereafter, we can ask ourselves, or in parallel, are the test results meaningful? And then we focus not so much on the truth in the test results, but on associations between the test result and other clinical pieces of information. And that's the clinical performance of medical tests. And a well-known example of the clinical performance of medical tests are diagnostic accuracy studies, in which we compare the test results against the outcome of a reference standard in the same patients, and express the results as a sensitivity and specificity of the medical tests. But the bottom line question in developing recommendations about medical tests, and also in reimbursement decisions, are questions about whether or not the testing as such is helpful. Is there a clinical benefit or clinical utility when we recommend the test? This reflects a change in outcomes for patients or for society, for example, when healthcare is made more efficient. Now, as discussed before, I would not like to present an overall view of all biomarkers in all areas, but focus on one specific area in which our team has performed a systematic review. And for that focus, we turn to ovarian cancer. Let me explain why we picked ovarian cancer. Well, ovarian cancer has seen a similar pattern in studies in which biomarkers were evaluated. So this slide presents the articles indexed in PubMed with biomarker and ovarian cancer in the abstract or title. And we see smaller numbers, but a pattern that's very similar to the one I showed before. In fact, even the 1990s saw already an interest in biomarkers in ovarian cancer. And over the year, there have been thousands and thousands of articles reporting evaluations of biomarker in ovarian cancer. Now, what has this massive effort in evaluating biomarkers in ovarian cancer produced? Have there been many assays that have been approved for marketing? And are these biomarkers now recommended in clinical practice guidelines? Well, the answer is slightly disappointing or massively disappointing, depending on where you come from. Overall, in the last few years, there's only been one biomarker that's now actually approved for marketing. Several assays are available, and that's included in guidelines, and that's HE4. And HE4 only to be used in combination with an already existing biomarker, CA125, and only for monitoring ovarian cancer, so not for diagnosis and not for screening. So how is it possible that this massive effort, this massive investment in biomarker research in ovarian cancer has produced only one new set of assays, only one marker? Well, to answer that question, actually, I would need a longer presentation or multiple presentations. But as a methodologist, I now focus on the methods that were used in the biomarker evaluation process. So there's not been a massive, let's say, output of the biomarker pipeline, but only a trickle. And maybe the methods are responsible for that trickle. So we performed a systematic review, not of the full biomarker pipeline, but focusing on one set of evaluations of clinical performance. So not analytical performance, not clinical benefit or utility, but clinical performance, for example, diagnostic accuracy. We performed a search of the literature, published literature in 2015, in which we try to identify studies, articles that report on studies reporting one or more measures of clinical performance of biomarkers in ovarian cancer. And I showed you that there are thousands, so we sampled 200 of them, 200 in 2015. And I should acknowledge the efforts of Maria Olsen and Mona Ganaat, who performed the evaluation. Now, these 200 studies were reported in 95 journals. Most were prognostic, but also diagnostic, predictive, and some screening studies. The sample size ranged, but the median was 165. The interquartile range around 100 to slightly less than 400. Now let's now turn to the methods. I don't want to focus on the results or the pathology, physiopathology, but focus on the methods. What kind of studies were these 200 reported in these 95 journals? What are some elements, key elements of the methodology? Well, to our surprise, only 12 studies refer to a protocol in running the study. And you may be familiar with drug research or randomized trials of surgical interventions. It's inconceivable that such studies would not have a protocol. But nevertheless, 94% of these biomarker evaluations did not mention having a protocol for the study. Only 5 of them provided a justification for the sample size. And you could question even the basis for that justification in these 5. Only 34 had explicit eligibility criteria. That's less than 1 in 5. So there was no description of the criteria for eligible patients, let alone criteria or mechanisms for identifying eligible patients. Many of them, around 1 in 4, used healthy controls. So not for screening purposes, by the way, but exploring these prognostic and diagnostic evaluations. Now, for screening I would understand, but not for these other purposes of medical testing. Only 7% had dedicated data collection, and 91% relied on secondary data already collected in clinical practice, and very often samples already collected in clinical practice. And about half of them were single-center. So the picture that emerges from this systematic review is not exactly a picture of strength. It's a picture of largely retrospective studies based on existing data collection in a single center, without a protocol, without eligibility criteria. You could say opportunistic research that did lead to publication, but you could wonder what this contributed to the biomarker pipeline. Our title was therefore that there are many shortcomings in the evaluation of biomarkers in ovarian cancer. Now, we used the same systematic review, the same set of 200 studies, to focus on another element, and that is spin in these study reports. And allow me a small introduction to present spin to you. As far as I know, the concept of spin was first introduced by Richard Horton, editor of Lancet. And he did so not in his own journal, but in a kind of debate in British Medical Journal, in which Richard Horton discussed the rhetoric of research. And this dates already from 1995. Richard Horton argued that peer review typically focuses on methods and results, but it frequently ignores a factor that deserves more attention: the manipulation of language to convince the reader of the likely truth of results. And he argued that as editors and peer reviewer, we should also perform a linguistic analysis of a report as a complementary process to other forms of peer review. To interpret a result correctly, we all, reviewers, statisticians, editors, and readers, should know the conscious and unconscious tricks of rhetoric by authors. Now, in the same article, there was a response from Tricia Greenhalgh. And Tricia Greenhalgh argued that scientific heads are not turned away by rhetoric. She's a medical writer, and she argued that we need spin. She said that linguistic spin is what draws us around the world to conferences, where oh-so-dry figures, tables, and structured apparatus can be finally discussed face-to-face. And the emotional and intellectual batteries can drive our research can be recharged. Well, obviously, this dates from pre-corona times. She argued that scientific papers stripped of spin will be science without buzz, a brave new world where technicians input data and computers generate scientific papers, while we remain bent over our whirring instruments. Now, this was somewhat jokingly, is spin by authors a good or a bad thing? For me, it became a serious thing once these three authors started a systematic analysis of spin. And from left to right, you see Isabelle Boutron, Doug Altman, and Philippe Raveau. Doug Altman is no longer with us, but he's from Oxford, and the other two authors lead a team in Paris. And what struck me was their analysis, published in JAMA a while ago already, on the reporting and interpretation of randomized clinical trials with statistically non-significant results for primary outcomes. And their rationale was that articles along the lines of Horton are not simply reports of facts, but that authors have many opportunities to consciously or subconsciously shape the impression of their results for readers. So to add spin to their scientific report. And spin is reporting, presentation or interpretation that could distort the readers. And they showed that spin was abundant in these RCTs that had non-significant results for the primary outcomes. So inspired by Boutron, Ravo, and Altman, we decided to analyze spin in a systematic way and look at these biomarker evaluations in ovarian cancer. So these studies of biomarkers in ovarian cancer, did they have spin in one form or another? Well, they did. Let me give you one example. This is a study of a marker published in Cancer Biomarkers. And the conclusion of the authors that you see is that this marker may serve as a useful diagnostic tool. But if you look at the methods, it's more of a discovery kind of study, which they included healthy women and women with benign disease, as well as women with advanced cancer. So very extreme phenotypes. And if you look at the box plots for the results in these various groups, you see a change in the median, but substantial overlap between the various results. So, is it right to refer useful when its use has not been studied? And is it right to refer to diagnostic tool when its use as a diagnostic tool has not been evaluated? I believe that this conclusion contains an element of spin. If we look at these 200 evaluations in 95 journals, we find that almost all of them has a positive conclusion about their biomarker, sometimes with a qualifier, but many times no qualifier at all. Only 7 had a neutral or a negative conclusion. And using a definition of spin, we found that 70% of these biomarker evaluations had one form or more forms of spin in the study report. Now I knew that spin was around, but I didn't expect it to be so massively around in biomarker evaluations. And it's not just biomarker evaluations, you find similar evidence of spin in diagnostic accuracy studies in general. Previously, we had shown that in a more restricted definition of spin, we found spin in 3 out of every 10 studies of diagnostic accuracy of biomarkers. For example, optimistic abstracts, stronger conclusions in the abstract, selective reporting in the abstract, conclusions based on subgroups only, or discrepancies between the study aims and the final conclusion. So in total, a strict definition would still leave us with 1 out of every 3 study with spin. And to my surprise, spin is also present in systematic reviews. So in systematic reviews, study authors combine several studies and present a conclusion based on all available studies. Now, in such systematic reviews, we also find spin. Most systematic reviews present positive conclusions, and a majority contain 1 or more forms of overinterpretation. I think it's very worrying. What are these practices? What does spin consist of? Well, it's an element of presentation and interpretation. It's a selective reporting of outcomes or subgroups only, selective reporting of analysis, or completely ignoring and not reporting uncertainty. For example, not presenting confidence intervals, or a mismatch between the abstract and the body of the article. Very often these articles have strong titles, strong abstracts, mismatches between conclusions and study design, or mismatches with results, or ignore the limitations altogether. What facilitates spin? Well, not having a protocol, no specified hypothesis, no pre-specified subgroups, no pre-specified thresholds. That facilitates spins, or not having a statistical test pre-specified. If you don't know where you're going to with a biomarker evaluation, it's impossible to get lost. Very often they don't report in precision or did not discuss the limitations. What can we all do to reduce this massive amount of spin in the biomarker literature? Well, we need protocols. All biomarker evaluations should have protocols. And we also need balance. We need balance in the team of researchers. And there should be at least one professional skeptic, somebody who's less positive about the performance of a biomarker and can be skeptical and critical throughout the process. Professional skeptics, please. So these are my recommendations to reduce spin. We should also publish the protocol, make it available, and register the trial. If we achieve the targeted sample size, we should celebrate. But in order to reduce spin in the study report, more measures have to be taken. Again, there should be balance in the team of authors. We should have optimists and pessimists, and they should discuss openly before writing the study report what the conclusion should be. They should also use reporting guidelines. Like this one, the START guidelines, the standards for reporting diagnostic accuracy studies. It's a one-page checklist that authors can use, and reviewers and editors, to make sure that all the essential elements of a study are included in the study report. And the START guidelines, the 215 update, also refers to an explicit definition of study objectives and hypotheses, and encourages the availability of a study protocol. It may not be in the final article, but elsewhere or as supplementary material. Maybe it's not such a bad thing to return to computers. This is a thesis that discussed assisted authoring for avoiding inadequate claims in scientific reporting. Because we know that peer review is not very good at removing spin. This is a sobering evaluation by the Paris team that looked at the ability of peer review to reduce spin in the abstracts of studies. This was for non-randomized studies. And the amount of spin stayed the same before and after peer review. The conclusion was that peer reviewers can identify many examples of spin, but their influence in changing spin is relatively low. Spin is worrying, and maybe we should change our publishing practice. Maybe we should invite reviewers or editors to write the title or the abstract or the limitations section of an article. And avoiding spin could mean that authors no longer have to write or can write these critical elements of a study article. So these are my recommendations to reduce spin after a biomarker evaluation, but they also apply to other types of studies. I'd like to present one more thing about reporting. There's a worrying amount of spin in biomarker evaluations, but at least the ones we identify were published. We could find a study report. How often are there studies that are finished, completed, but never published in a peer-reviewed article? Well, to answer that question, we turn to clinicaltrials.gov. And clinicaltrials.gov may be well known for its clinical trials in drugs, drug development, or surgery, for example, but it also has records that refer to biomarker evaluations. So Daniel Korevaar and a couple of colleagues identified evaluations of biomarkers or other medical tests registered in clinicaltrials.gov. And we focused on our records with a study completion date. With the study completion date, we could see when the study was expected to have finished and whether the study was available as a full text report. Well, within 1 year of the completion date, only 1 in 5 of these studies were reported. After 2 years, it was less than 40%. And the number increased, but even after 5 years, 40% could not be identified in the published literature. So many studies remain unpublished. And don't blame the journals. In additional research, we found it's the study authors that are responsible for the failure to submit their study or resubmit their study. I've shown that there are methodological shortcomings in the biomarker evaluations and that there's abundant spin. But maybe there's a problem with the biomarker pipeline in itself, this transition from discovery to translation, evaluation, implementation. It's not a neat pipeline because there are cracks, leaks, and waste everywhere. And John Ioannidis and I wrote a commentary on this in Clinical Chemistry. It's not a neat pipeline, but has massive waste and leaks. And we should reduce altogether waste in producing research evidence. There's waste in asking the wrong questions, in using the wrong design and methods, in failure to publish, and failure to be informative in the study report. Authors, Ian Chalmers and Paul Glasziou, have estimated that in general, in clinical research, 85% of the research efforts are wasted. They don't produce evidence. These studies do not produce evidence that's relevant for clinical decision making. But maybe there's more at stake here. I think there's a more fundamental issue with the notion of a biomarker and a pipeline. This is the best known definition of a biomarker, and it refers to an indicator of processes. But in order for an indicator of processes to become a medical test, we should look at the purposes of medical testing. And the best known purpose may be diagnosis, but it's not the only purpose of medical testing. We also have staging, prognosis, monitoring disease, treatment decisions, surveillance after treatment, screening, early detection, risk stratification, predisposition. And these studies do not just require an indicator, they require a medical test that is fit for purpose. And the purposes on these slides are massively different, as are the populations in which we'd like to use these tests. So my argument is that we should take into account the two views that exist on the value of medical tests, an essentialist and a consequentialist view. I believe that the biomarker literature is still focused on the essentialist view, the theory that the value of a marker or medical test should be judged by the trueness of its results. Whereas for medical tests, we should be consequentialists. A marker or medical test is useful, is valuable when the consequences of using it are valuable. And that means that we have different focuses for essentialists and consequentialists. One does not exclude the other, but for making recommendations, consequences are more important than truth. So we should revert the biomarker pipeline. Rather than thinking about discovery, we should focus on the unmet clinical needs for biomarkers, asking ourselves, what's the health condition? How can clinical management be improved? And identify the unmet clinical needs, as shown on this slide, from the European Federation of Laboratory Medicine, and then think back how we could find biomarkers that actually address these unmet clinical needs. I know not all hypotheses will be confirmed, and as a clinical epidemiologist, I help in most of my studies with processes about mourning and grief over these prematurely burned hypotheses. Not everything that we expect to work will work. That's actually an essential element of all research. But biomarker research actually is especially vulnerable, balancing between hope and hype. And I think this has to be changed. We need stronger studies, we need better reporting with less spin, but maybe we have to rethink the biomarker pipeline, focusing less on discovering extreme phenotypes and thinking more about unmet clinical needs in target populations. And with that, I'd like to thank you for your attention, and I'm happy to answer questions during the discussion. Thank you so much.
We've got a few coming through. I just want to kind of kick off with the first question. So I think some of the graphs that you showed of the increasing number of publications is very reminiscent of some of the charts that we looked at when we first started in breath research. We were coming at it from the analytical instrumentation side of things, and the raging skeptic in me was saying, well, for so many papers, where are all the breath tests? And I think that was especially true when we started to look at the literature in VOCs for lung cancer. So there's a lot of papers published, and most of them were saying it was a positive result, yet they didn't particularly agree with each other, and they haven't been independently validated, etc. So I can very much see that 96% positive conclusion ringing through in some of the things that we've seen within the breath field. So the first question I wanted to ask relates to the notion of using extreme phenotypes. So I get that often there's an overreach or spin in terms of extrapolating what a result may mean from a diagnostic utility standpoint. But I'd be interested in your view to the utility or lack thereof of using extreme phenotypes in the kind of early research phase, because I suppose you can make the same argument about the use of animal models or in vitro models where you have a will this translate type risk, but it's obviously a lower cost de-risking experiment to run compared to working in a representative population or intent to diagnose population first. So interested in your perspective there of where should these more extreme phenotypes be used, or should you go much closer to the intended use in the first instance?
Well, I think, thank you very much for that question, Billy, and for your comments. I think there's a difference between, let's say, scientific research as such, trying to understand mechanisms in pathophysiology, and test development. So, and I have nothing against case control studies, and sometimes it can be very efficient to take rather extreme phenotypes in order to confirm or refute a mechanism about or the existence of a specific risk factor. But that's several miles away from developing tests. For example, in the intended use setting, you rarely see these extreme phenotypes. For example, in cancer screening, yes, we may see people with advanced stage cancer, but very, very, very few. Most will be asymptomatic and early stage. So the extreme phenotype study will tell you very little about the performance of that same marker in the intended use setting. So if your main focus is to explore potential markers as medical tests, you should be much closer to the intended use setting and look at the spectrum of the disease in the spectrum of whatever condition you're looking at that's visible, that will be represented in the intended use setting. And I haven't specifically explored the breath marker literature, but there also you see a very large dominance about extreme phenotype designs with excessive claims about the likely potential of that marker as a future medical test. And I've used the ovarian cancer as an example. But I think it's fairly representative of most areas of cancer and most areas of clinical medicine, that the whole biomarker pipeline has produced very few markers that are nowadays used as medical tests in clinical medicine. And some of those that have been introduced, the discussion is ongoing about their actual clinical benefit. So it has some merit, Billy, for scientific research, but the merit in test development is extremely overstated.
Yeah, that makes a lot of sense. We have a question here from Chad. Great talk, great recommendations for researchers. How do we tackle the environment that promotes spin? How do we balance reducing spin with the bias against publishing negative results and the publish or perish pressures faced by junior researchers?
Yeah, that's for me, that's a familiar comment. When I present this to PhD students, they look surprised and say, well, you're telling us not to use spin, but that's what our tutors and our supervisors teach us. Because if we don't use spin, nobody will be interested in our results, and the journal will not be interested, the funders will not be interested. I don't believe that's true. I think I can myself, actually, I based a career on negative results, trials that turned out differently, randomized clinical trials with a different result than expected, and test evaluation that produced less favorable results than initially expected. Yet these were all published by journals, and despite the fact that the conclusion very often had to be negative. So I think it's a common mistake that nobody's interested in a negative results and a negative finding, especially in evaluations. I think in early science, if you try to discover something and you failed, maybe people are less interested. But there also, people argue that you should publish your failures. In test evaluation, it's not so much, I think, the result that matters, it's the quality of your study, the rigor by which you apply the methods, and then the results will be interesting for the medical community and the medical journal. So both the amount of spin and our failure as a clinical scientific community to submit studies with negative findings because we believe that nobody will be interested in them, these are worrying things in the scientific in the scientific community. So spectacular results are interesting and are more newsworthy than confirming what we already know, but spectacular can be also in a negative sense. A failure to confirm, for example, that a previously putative biomarker is powerful in terms of clinical information is also newsworthy. So I would like to invite all of you, all the participants at this conference today, to submit their results, whatever the conclusion, be it positive or negative, but to submit them to journals.
Thanks, Ed. Yeah, a few questions that come in along similar themes, particularly thinking about how to get additional funding as well. But I think you've largely covered the theme there. Question here from Mansoor. Thanks for the really informative talk. How about something simple, especially considering the number of biomarkers that are often tested simultaneously, such as lowering the threshold for statistical significance?
Yeah, very often studies will not look, in the discovery phase, will not look at one specific marker, but will look at, for example, a range of proteins and then test every single one of them for significance. And even if they lower the bar for us to account for multiple testing, I think there's still a risk in the basic study design that without any prior knowledge, you're just shooting at 100 or maybe several thousands of proteins in a random fashion. And the chances of producing a false positive results are still substantial and somewhat even underestimated, I think, if you look at it from a Bayesian approach, by just looking at the Bonferroni corrected threshold for statistical significance, for example. So yes, lowering the bar for statistical significance makes sense in a general way, but it does not prevent the false positive findings. Keep in mind that in our review for the biomarkers that we looked at for clinical performance, a majority of studies did not report the uncertainty in the measure of the performance. They did not include confidence intervals. They didn't have a pre-specified hypothesis test. And sometimes we suspect that the test that they used was selected after they had collected the data and looked at the findings, which is in general, a common mistake. So draw the rules before you start playing the game.
And that kind of leads into the next question. So it seems within biomarkers and diagnostics, and it can be gamed to an extent if you're not setting out the expectation beforehand. So do you think there's lessons that can be learned from therapeutics, for instance, or other areas where it seems to be a little bit more definitive, that positive or negative result? I'm just kind of interested in your thoughts there.
Yeah, so I do not, if we look at therapeutics, we know that there are many molecules studied and many potential drugs studied, and there also the pipeline does not generate a tremendous amount of treatments. So I'm not suggesting that everything that is discovered in the biomarker literature will eventually, given better studies and less spend, could be developed in a medical test. So that's one lesson to learn from therapeutics, that it takes a lot of failures before you can come up with a success. So that's one lesson to learn. But also there are a series of steps, I think, in the development therapeutics from which we can take lessons if we're interested in not just, and for example, in bread biopsies and future medical tests. And that's all the sound rationale for a specific marker to become a medical test. So it's not just based on a single study, on a single discovery, but it's based on a network of knowledge in which we understand whatever the marker, we try to understand whatever the marker is doing and how it could eventually be used as a medical test within the intended use setting and for the intended use population. So there's too much. The biomarker pipeline suggests that we only need a series of studies of the biomarker in order to develop a medical test. And I think that's too simple. We need a full knowledge about what the marker is doing and benefit both also from basic science and other areas of scientific research.
Excellent. Probably have time for 2 more questions. So here, you mentioned the main value at early stage discovery research is to show clinical validity. Should the community focus be on p-values or clinical performance in the field?
I think, Murat, that's almost an open question, because in the end, what matters for medical tests is a clinical benefit and clinical utility. Are patients or society better off from using the test? So very early on, we have to think ourselves, how could patients benefit from using this marker as a medical test? And that does not rely on p-value. It doesn't even rely on clinical performance, because a marker could have clinical performance, but that information could not add. It's possible that the information does not add anything to what's already known. And in that case, there's unlikely to be a clinical benefit. It's also possible that the marker generates meaningful information, but you don't have the next steps to act on that next piece of information. So what matters in the long run is a clinical benefit. And whenever we try of a biomarker as a potential benefit, we have to think about the intended use and how this would benefit patients. So sometimes people come to me that believe that they have discovered a biomarker, and they say, we now want to design the next study. But then my return question is, what's your value proposition? How is this going to improve the lives of patients or the life of clinicians? And that question should be addressed early on.
A question here from Mark Woolen. Do you have any comments on machine learning or multivariate analysis of biomarkers and spin?
Well, in my initial explanation, Mark, of the literature on machine learning, I see that spin is almost as abundant as it is in biomarkers, in proteomics, for example, or in more general clinical chemistry. So, and there's a major risk that machine learning in itself will become a new element of hype for future tests, that just having machine learning and AI is a value proposition in itself, which of course isn't. Machine learning should be evaluated like other potential putative medical tests in terms of its clinical performance and its clinical benefit.
Excellent. And then time for one last one from Scott Harrison. The advances in metabolomics has been a result of being hypothesis-free. Are you saying their discovery work is invalid?
I'm not saying the invalid will be too strong a statement, Scott, but I think it generates a lot of false positive findings.
Excellent. Well, thank you so much, Patrick. It's wonderful to have you on. Food for thought for a lot of us here.